This session, this is a whole body MR session, and it is split into 3 parts. Stefan Schönberg, to the right of myself, is talking about the non-oncologic applications. Then Tobias Haye is covering the oncologic applications, and Prakash, difficult for me, sorry for that. Prakash is then focusing on the pediatric applications. You already know how the evaluation system works by now. There are no barcodes any longer. It's all online. And without further ado, I would like now to introduce Stefan Schönberg. He's the chairman at the University of Mannheim, and he is well known in the field of MR. Stefan, please.
Thank you very much, Elmar. I also like to sincerely thank you that you put this together, this great course, because I think it's a very clinical orientated course of a technology that has been around, I would say, at least for over 10 years, and we see now to shapen up the different applications in the oncology, non-oncology field. So again, thank you very much in the name of all of us. So it's my pleasure, good morning ladies and gentlemen, to speak on the non-oncologic applications, which in the first thought, there's not that many, but if you think a little bit more in detail, there's actually a number of great applications that also turn into true clinical utility, and I'm very happy to share those with you in the next 30 minutes. Now, the learning objective is basically to understand the indications in the non-oncologic fields, to optimize the protocols, and also to show the additional diagnostic value. I think this is very important for us in radiologists. We hear this all the time in comparison to routine diagnostic tests. Now, a few words on the technique. The issue of accuracy, for example, for whole body MR angiography has been virtually solved. It has been shown that particularly if you go to 3 Tesla and you have an isotropic resolution of like 1 millimeter in the entire field, you have a high inter-observer accuracy and very high sensitivity and specificity. And this is basically now implemented on most systems, but again, 3 Tesla is beneficial because you save contrast. So the message is high resolution turns into high accuracy, and I think this is something we can take for granted. There's different approaches, and I would like to point your attention to this nice review article. You can always use many coils, so it's ideal to have a system that has multi-channel equipment, which is true for most of the vendors these days. And you clearly see that there's either the possibility to use the coils for the top of the body, do the selective injection here for the carotids, and then for the remaining vasculature, you basically switch the coils and then do a run-off study. Some other concepts is to introduce a rolling table platform where the coil stays static and the patient slides underneath the coil. Or with the multi-channel systems with channels of 32 or even more, you can use those coils evenly distributed over the entire body. And this has been also implemented by several vendors. And this, of course, gives you very high flexibility to adapt your protocol specifically to the needs of the territory to be studied. A very appealing approach that has been co-developed both by the group from Mayo as well as Essen is the so-called continuous table movement. Here you do a different kind of case-based acquisition. First, you Fourier transform the data in readout, then the object moves in readout, and then you store that data in a hybrid case space, and then you do the phase encoding, and once the data set is complete, you truly do your Fourier transform and your image reconstruction. And this results into a contiguous 3D data set, which is kind of really nice for looking at the vasculature in high continuity. So it's a very elegant technology, again, has been picked up by different vendors for their implementation. Now, with regard to contrast agent, there's one contrast media called gadophosphosid. It's available by one company at this moment, and this is, can be used both for first-pass imaging here with high resolution, but ideally even in the steady state, because it's in a strongly albumin-binding contrast agent with a high relaxivity and high intravascular remanence. And you see that in the steady state, you can, for example, do high-resolution imaging, even ideally in the coronaries, but at least very high resolution in, for example, the calves. So this helps you to come up with morphologic and functional protocols. This is a case here where you have a time-resolved perfusion study in the lung. You can measure blood volume from this. Here's the blood volume image that turns into a parameter map of pulmonary perfusion. And then, after the first pass, you go to ultra-high resolution. This is in the calf, and this is a sub-millimeter 0.3 isotropic resolution, or 0.4 isotropic resolution. And this helps really to separate out arteries and veins quite elegantly. So I'll show you some implementations in clinical routine later here. So what are these clinical applications? It's a screening for cardiovascular disease, not just for normal individuals, but really for risk assessment, for assessment of underlying disease, particularly in affected groups such as diabetics, looking in venous thrombosis and pulmonary embolism in a radiation-free protocol, but then the huge area of rheumatic disease such as vasculitis, seronegative spondyloarthropathies, chronic recurrent multifocal osteomyelitis, and connective tissue disorders. And also very nice application in clinical routine is for immunocompromised patients going, for example, bone marrow transplant, the assessment of fever of unknown origin. So let's start out with the assessment of atherosclerosis. We did a study in healthy, not asymptomatic individuals in a larger study with lasted for about 3 to 4 years. And we could show that in middle-aged, predominantly male individuals, atherosclerotic disease is not uncommon. And even those individuals were all asymptomatic. About 25% had vascular abnormalities. And the good thing is 99.8% of all the vessel territories were accessible by whole-body MR. So it's a robust technique, and it indeed shows the prevalence of atherosclerosis. Now, what is this good for? Well, it has shown, and I think I really have to refer here to the group from Hakan Alström in the University of Uppsala. They did the prospective investigation of the vasculature in Uppsala seniors, and they could show that if you make a score out of your findings from whole-body MR and you correlate this to established measurements of atherosclerotic burden, you have quite a nice correlation to also other functional parameters in atherosclerotic disease. They could show a significant correlation to the vascular compliance between their total atherosclerotic score derived from whole-body MRA in comparison to the compliance. And this could show that indeed whole-body MR is kind of a marker for the burden of atherosclerotic disease. While, for example, the endothelium-derived vascular dilatation, which is typically measured in the forearm and not so much affected by atherosclerosis, interestingly, did not significantly correlate to the total atherosclerotic burden as measured by whole-body MR. So it really is a measure of arterial compliance, and this is quite interesting, because you can also correlate this to other systemic mediators of atherosclerotic disease. They could find in a follow study in atherosclerosis that the total amount of whole body fat did significantly correlate with their score of the atherosclerotic burden. So it's a true biomarker measurement. I think this is the view we have to have in the future, not just counting stenosis, but consider whole-body MRA as a biomarker for its ideally prognostic assessment. We did something similar, but these were not asymptomatic, but symptomatic patients, where we looked at different factors influencing survival in patients with peripheral arterial occlusive disease. And the interesting thing was, in a probabilistic model, that the most important factor separating different groups of survival was the number of patent vessels as seen on whole-body MRA. And you could see this. If there were 0 open calf vessels, the mortality is higher than in cancer patients. But even if you have an incremental increase in the number of patent vessels, it still separates those patients. And this, I think, is quite an enormous thing that we can look into survival based on those quantitative measures. Becomes even worse if you look at diabetics. We know diabetics have a high incidence of macro and microvascular complications, such as peripheral vascular disease, angina, pectoris, stroke, but also a lot of microvascular complications. Now, whole body MR is ideal in these patients. You can combine, for example, soft tissue assessments, such as here in the inflammatory changes of the joint, and do whole body MR, and then combine this also with, for example, cardiac imaging, late enhancement imaging, as well as looking at the brain for chronic vascular disease. And this is a typical case. This is a single patient with like occlusion of the middle cerebral artery, bilateral carotid stenosis, bilateral renal artery stenosis, and a myocardial infarction. And we compared these diabetics to our controls from the previous studies of the asymptomatic individuals, and you could see the enormous difference in the vascular, both micro and vascular complications. If we look at this a little bit more in detail, we see particularly in peripheral vascular territories, there's a highly significant difference, while, for example, for the common iliac and internal iliac, that difference is not true. So it's really not worthwhile measuring with Doppler the flow in the iliac artery. It's really those microvascular complications elegantly seen on whole body MRI. And this is an example. The macrovascular territory in this lower leg image of the whole body MR still shows patent vessels. The cardiac function appears to be normal, but this patient has a totally unknown silent myocardial infarction, and she also had long-standing diabetes. Now we know that there already are biomarkers in diabetes, and which is coronary calcium score. Calcium score already in the asymptomatic group of us in the general population is very predictive of cumulative survival in terms of the total burden. And this just becomes even worse in diabetics, separating out different groups with different survival based on their total calcium load in the coronary calcium score. So what we did together with our diabetologists in Munich in former times, we calculated a total MRI score and compared this to the number of metabolic syndrome components, and you see somewhat increase. And what is kind of really impressive is that score, that total whole body MR score, is highly predictive of severe negative outcomes in cardiovascular disease, such as fatal death or stroke. And this can be shown here. It has quite a good correlation to the whole body MR score. So 5 years later, my former colleague, Fabian Bamberg, called all these patients in again and looked at those who had a normal whole body MR score and those ones who had a significant change on their whole body MRI score. And he could show a large difference in terms of the event-free survival probability based on whole body MR. So us as the radiologists created a biomarker which really separates out those people in terms of long-term survival if they have a normal or affected score. And this becomes even worse if you look, for example, at the vessel score. It really separates out the patients very elegantly in terms of the event-free survival. If that score is greater than 1.45 or smaller, it really has a high separating predictive value. So shifting gears from atherosclerosis and arterial disease to venous disease, of course, using the intravascular contrast agent, you can elegantly use whole body MRI for venous thromboembolism. This is the perfusion study I showed earlier compared to scintigraphy, nicely showing those peripheral perfusion defects here, like on the segmental level. But then in the steady state, we can do high-resolution pulmonary MRA, seeing the thrombus in the lower pulmonary right artery, here in multiplanar imaging. This is the CT comparison. This is then basically done in the abdomen, where you see the large thrombus in the IVC. Again, this nicely compares to the CT. But what's even more helpful in the peripheral vessel disease, venous area, where it really becomes hard for Doppler sometimes, You see the occlusion here of the main femoral vein. You can see this in multiplanar reformat here with the thrombus inside. This correlates to ultrasound in the superficial vein, femoral vein, and then even in the calf, using the ultra-high resolution, you can see the thrombus sitting in there. And this is really elegant. The total table time in that study was only 15 minutes. So something really to further exploit. Now, going from the vascular to the autoimmune diseases, I think it's really both for vasculitis and for rheumatic joint disease, such as the SPAs, the CMO, or the connective tissue disease. Whole body MR is really a very powerful technique. So looking at Takayasu's, we know that there's different types. Here, this is a type 3, where both the aortic arch and the abdomen is affected with a bilateral renal artery stenosis, this typical classical tapering of the renal arteries in the inflammatory setting. And there's a study by Lee in the JCAT journal looking at 42 patients, and what they could find is that in comparison to the Lupi-Herrera's classification, that also has implications for therapy, the combination of whole body MR, pulmonary perfusion assessment, and vessel wall imaging really caused a significant upgrade of this classification in 8 of the 23 patients. So it's really a very powerful technique also to classify these patients adequately for the right therapy. And here's an example where you both have massive aortic arch involvement, but also this is the type 4, where the pulmonary artery is involved with lack of perfusion here. And then you see the typical abdominal involvement with this tapering stenosis. And then if you look in a high resolution, you also see this thick inflammatory vessel wall around the aorta. So this was really, I think, a nice study and helps to further classify these patients. Now, in joint disease, again, the combination of time-resolved imaging. This is a patient with rheumatic joint disease with a time-resolved 4D MRA showing the typical hypervascular synovitis. You can combine this with high resolution both for the joints in the hand and foot. And you see, for example, here in this rheumatic disease, the typical manifestations here in the carpal and tarsal bone area. My favorite is the seronegative spondyloarthropathies, for example, the psoriatic arthritis, because these are really kind of hard to tell for the clinicians how much these are affected, because these patients typically have sometimes very vague pain. For example, this is a patient with psoriasis where you see, of course, the typical involvement of the of one finger, like here in the thumb, and the same thing also occurring in the foot. But still, there's also synovitis, there's enthesitis here in the interspinal ligaments, and this is really only nicely to be assessed with whole body MR. It's even more impressive here. You see the typical enthesitis interspinal, you see the one-sided sacroiliitis, and you see the synovitis all together with this enthesitis here of the symphysis together, involving also the tendons of the adductor muscles. So I think this is a really very nice approach, and particularly for those disease-modifying anti-rheumatic drugs like TNF-alpha. It's very important because they're really expensive, that you have a very objective assessment of the disease monitoring. Same is true for the spondylitis ankylosans. This is a patient with a long-standing disease where you see sort of this already bony syndesmophyte, the burned out sacroiliitis both sides, and you see the aseptic spondylitis here in this particular case of seronegative spondylitis ankylosans. Now, I think particularly when it comes to children, it's our true responsibility to more often use whole body MR. CMO is also an aseptic, abacterial, autoimmune mediated disease with chronic inflammation of the bone. And you can see this so exquisitely already in whole body stir images for assessment for relapse, which typically is quite common. I think there should be no other technique than whole body MR to scan these patients and assess the disease burden. This is also true for mixed connective tissue disorders. This is a 17-year-old female with dermatomyositis, and she has a severe inflammation of the muscle and the subcutaneous tissue. And this is pre-treatment. This is courtesy of my good friend Roberto Dominguez from Rio de Janeiro. And of course, this is an entirely radiation-free procedure, particularly when you follow up these patients. Here is the after-treatment, anti-rheumatic treatment. You see that this, all this inflammation is virtually gone, and I think it's very exquisite to be followed up by this. There's other indications occurring, which are, I think, appealing. For example, in muscular dystrophy, the Duchenne type can be assessed in its severity. There's minor and major forms. And this, for example, is a high-grade form where you see the entire lower body is replaced by fat. And this can be nicely seen on the whole body MR scan. Why it's kind of really important for these clinicians, if this is only intermediate severity, you see here, there's still parts of the anterior tibial muscle remaining, while there's huge atrophy, for example, of the posterior muscle in this particular case. And I think this is a nice way of assessing this for the clinicians who need to know how they basically also manage that patient. Now, my last field, I think, really has also entered the clinical routine. Actually, we start to do this routinely instead of PET in our hospital, but because reimbursement in our country is relatively poor. We only get lung cancer reimbursed for PET-CT. So the clinicians love this. This is the fever of unknown origin protocol. It's defined by fever of more than 38.3 Celsius and chronic more than 3 weeks. And it's basically an indefinite course with 1 week of despite 1 week of adequate diagnosis. And most common etiologies are infections, neoplasm, inflammatory diseases. And in the past, we only had indium-111 granulocyte scintigraphy or, as mentioned, PET. And MR, there was really no data. So what we did here is add whole body diffusion to the protocol, in addition to stir and contrast imaging. And this is really nice. I'd like to draw your attention here to the femoral muscles here. If it pops up, this is the inverted DW image, and you see here a lot of diffusion restriction in the here in the anterior compartment. And this is the same patient, where then basically the diffusion also shows a lot diffusion restriction here in the supraclavicular fossa. And the reason in this particular case, the patient had a previously unknown severe septic arthritis of his left shoulder. And of course, X-ray is entirely useless. In this particular case, this is the overlaid image of STIR and the DWI. We really give the clinician a PET-like appearance in this particular case. Another case here, patient, again, with a negative workup with gallium scintigraphy, and we did whole body diffusion. This is the fused image of DWI and STIR. And in this particular case, it was negative. There was no real infection. It was only soft tissue edema, and this patient was negative. Now, we did that study in 24 patients, compared this to the standard protocol workup, and amazingly, 50% in inflammatory focus could be detected solely by MR, leading to an immediate treatment change in over 90% of the cases. And of course, this is again comes in a very radiation-free environment, which I think is particularly in young patients extremely helpful. So in conclusion, morphologic and functional staging of vascular disease is now, I think, without doubt possible with very high accuracy, and there should be standardized protocols available on every scanner to do this robustly with high accuracy. What I think is important, and this enters the arena of precision medicine, MR is not just a stenosis counting machine. It is a new biomarker for risk assessment with important clinical endpoints, such as major cardiac events or event-free overall survival. I could show this in diabetics. I've shown this also in symptomatic patients with peripheral vascular occlusive disease of atherosclerotic type, but also like in the PIVOT study, you could see that this is also possible in the asymptomatic group. It requires, and this is important also for the vendors, it requires quantitative scores as an important link to clinical outcome. I think this is important. We have to sort of have normalized scores. And I think it's a really reliable tool for staging and particularly therapy monitoring in rheumatic disease. The clinical value for detection of fever of unknown origin, I think, is established, particularly with the implementation of more recent techniques such as whole body diffusion weighted imaging. And with this, I'd like to truly thank you for your attention.
Yeah. Stefan, thank you very much. That was great. We do have time for a couple questions or comments. Okay. Let me do a raise of hands here. Who's actually doing whole body MRA currently? Okay, I see maybe 10 hands going off. This is probably in the range of 10 to 15%. The next thing was the field of rheumatoid diseases. Who's using whole body MR in that field? I see 3, 4, 5, 6 hands. And finally, fever of unknown origin. Okay, good. Now, who plans on? Okay, we are not going there. Okay, but I do think there is a lot of potential. There is certainly a clinical need. And I'm always puzzled when people tell me the in-room time is only 15 minutes. And I usually think, yeah, right. Okay, Stefan, how long does it really take? Yeah?
This is the story behind it. It's entirely different, as we will probably hear later, for oncologic implications. I mean, can we not afford to miss a liver lesion simply due to a fast and, easy protocol? But this is a different setting here. I mean, here we truly, for children, it's essentially with a whole body stir, like in one case you have, you're done. Same is true with for example, in the fever of unknown origin. We only do a head-to-toe, even with continuous table movement, a T1 weighted scan, and a coronal DWI, for example. And that's it. And then you're really in that range. But this is easier. It's a very important question. Thank you very much. It's easier in the non-oncologic field than in the oncologic field. In the oncologic field, honestly, our protocols still take 45 minutes because we do a lot or more, because we do a lot of interest in there. We don't want to miss a single lesion. Here, it's a systemic disease assessment. It's not so much the single lesion that you want to see. So it's a little bit a different ball game. Yeah.
Okay. Thank you very much, Stefan. We are now moving on, and our next speaker is Tobias Haye, and he will focus on the oncologic applications.
Good morning, everybody. Thank you for the introduction. In the next 30 minutes, I'll try to cover what the potential of whole body MRI is in oncologic applications, give you a little bit of insight how disease-specific protocols may look like, and also we have to look at the competition that's out there. How is it performing against the whole body MR? Before we start looking into specific approaches, I want to start with some general considerations in that field. Why are we actually doing whole body MRI? I think some of that was already mentioned. We have more than one contrast. It's superior soft tissue contrast, and we can actually acquire additional information, quantitative information that may help us to evaluate disease activity or response, and plus we don't have radiation exposure. But on the other hand, we have some downsides as well. We talked about acquisition time. It's usually quite long. There's actually not a lot of data if it's cost effective compared to other modalities or not. There's a problem who reads it actually. If you have a subspecialized department, how do you cope with that? Who's reading the head and neck? Is it the neuro guy or is it a specialized person for reading whole body MRI? And there are also some implications concerning the patients, and the risk profile of MRI is a bit more difficult and diverse compared to the other competing modalities. Whenever you do MR, you have to respect this triangle. Whatever variable you change here, it may inversely affect the other variable. If you do whole body MRI, the body region coverage comes into play as well, makes it even more complicated, and all these factors affect the patient comfort. And if the patient is not comfortable, it may inversely or adversely affect all the parameters you're actually aiming for. Now, how does it look like when you set up a patient with a whole body MRI system? It's actually encased with coils from head to toe. And thanks to Professor Merkel, I have an example here that shows an experienced tech preparing a patient, putting all the coils on the patient from head to toe, making sure he's comfortable. You may want to ask him if he has to go to the restroom before you start scanning, because otherwise he may get uncomfortable. But even this experienced tech takes roughly 5 minutes to set up the patient. It's something you have to take into consideration if you come up with your time slots for whole body MRI protocol. There are some other things I want to mention. So when you do whole body, you may find other things that you're actually not looking for. And this study here on roughly 150 healthy volunteers, they found 30% abnormal scans. And in 13%, these abnormal findings were clinically significant. And the ones that they rated as highly clinically significant, they had to do invasive procedures such as surgery or biopsy or follow-up to actually cope with these findings. So you have to have a game plan in place to really know what to do with these findings. Another factor might be the psychological effect that finding all these things in patients has. So in this study, roughly 500 participants, was a health study on general population, and they knew that they could potentially receive a notification of the incidental findings in this study. And they were also supposed to rate what the findings were in terms of severity, and that was compared to the professional perspective. So while most of them were interested in learning about their health, 10% perceived or experienced strong distress even prior to receiving that notification. And then later, when they received it and there were some findings, 30% were moderate to severely distressed. And they didn't kind of concur with the professional perspective on what was actually severe and what not. These are just some side remarks when we look at whole body MRI. It's something we have to take into considerations. Now, let's go into protocols. So as we said, we cover from head to toe. We have either continuous tail movement, or you have the overlapping sequence acquisition. And you can use all the sequence and contrasts that are out there. You can add additional flavors. You can go crazy and do a very complex protocol. But in most cases, actually, in the oncologic protocols, you'll find non-contrast applications, mostly T1-based stir imaging, and possibly added diffusion-weighted imaging. And that could result in a protocol anywhere from roughly around 30 minutes to well beyond 60 minutes. And if we put in the relationship we established earlier, it gets even more complicated. And you also have to consider that most people not only do one orientation, but they also do another orientation in sagittal, for instance. Now, one particular technique that evolved in 2004 by Takahara et al. Is the whole body diffusion-weighted imaging with suppression of the body signal. What they did, they showed that this technique gives you a PET-like experience if you do the MIP reconstruction and invert the images. It has very excellent lesion to background contrast, and therefore is able to detect even smaller lesions. And these are some examples of their publication. As you can see here, the background suppression on these chemically selective fat set is quite poor compared to the strong suppression here using the stir technique. And you were able to identify these cervical lymph nodes in that patient. They also demonstrated that in finding the extent of disease in this patient with lymphoma was quite easy with this PET-like experience. And you could also identify really small lesions. I mean, they showed that they could identify peritoneal implants from a patient with ovarian cancer, which are also seen on a PET-CT, but these lesions are always difficult to find. Now, how does it usually work? You have your morphologic sequences, the stir and the T1. You acquire the diffusion-weighted imaging. You invert the images, and you can superimpose them, fuse them on the morphologic sequences, and it would give you an added benefit of finding lesions such as the one in the iliac bone here, which is not so easy to detect on the morphologic sequences. Another side comment I want to make on reading all that data. I mean, we're doing whole body MR. That per se means we're acquiring lots and lots of data. We're doing multiple contrasts, multiple orientations, and we have to read all that. And then I encourage you to also look at the raw data, basically, to look at every sequence, because there you would have better detail compared to the composed images. You've probably seen all this, the study that came out that showed that 83% of radiologists in that study were able to miss this gorilla that sat here on CT images while they were supposed to find the lung nodules on the CT scan. Now, if they were supposed to find something we see in everyday life, we have to be very careful and when we look at whole body MRI not to miss the gorilla here. Now let's move on to some more disease-specific approaches. A good, like the poster child basically in whole body MRI is multiple myeloma. I hope I can show you how MRI evolved into a mature clinical application. Usually what you do is a T1 and stir-based protocol in coronal and sagittal orientation, and oftentimes you would include diffusion-weighted images. The goal is to really stage the extent of disease. You want to look for diffuse or focal pattern of infiltration. There's the Dewey-Salmon staging system, and we'll look into that, and we also see what the competition does. Now, there's a first study that looked at whole body MRI, really used a very fast protocol, just coronal stir imaging, with a total acquisition time around 8 minutes and a room time around 50 minutes, which was actually quite fast and faster compared to the skeletal survey, which until that time was the standard for multiple myeloma. And what they found is that in 74% it was concordant with the skeletal survey, but in 90% of the cases, whole body MRI was able to find more bone involvement, more extensive disease. And that led to upstaging in these cases, in actually 20% with an impact on therapy. And they also had no false positive findings compared to the skeletal survey. So whole body MRI is better than the skeletal survey, but in order to understand the development here, we have to take a step back. And we look at this study from Bauer et al., which basically is not whole body MRI, it's actually just spine imaging. And they proposed a staging system. They said stage 1 is a normal appearing bone marrow, such as this. You all know how that looks like. They said stage 2 are 1 to 10 focal lesions or diffuse infiltration based on the T1 signal. And you can see that here you have diffuse changes, very homogeneous changes on the T1, on the vertebral bodies compared to the discs, and also increased signal on the stir images. So you can assess diffuse infiltration here, but you have to be careful. If you look out for focal lesions, you might find this one here in the iliac bone. That is a common pitfall in multiple myeloma and other hematologic disorders. That is actually the access route of the bone marrow biopsy. You can tell by the adjacent edema in the soft tissue. There's also a pattern called the salt and pepper pattern, which is a more heterogeneous infiltration of the bone marrow. You can see you have islands of bright signal here on the T1, which is still fat, and it's considered a more mild infiltration pattern. They also came up with a stage 3, which is more lesions, more focal lesions, and a more pronounced diffuse infiltration. Now they incorporated their staging system also with the existing Dewey-Salmon staging system, and what they basically did is they compared how the staging system would perform. And there's the combined staging system actually outperformed the others. So you can see nicely separated out the different disease stages. And whereas the initial Dewey-Salmon stage 1 had 5 patients who died in that group, which is not the goal really of a stage 1, the combined protocol had no patients dying in stage 1. You can see a patient where you have diffuse infiltration of the bone marrow, you have multiple focal lesions that you can easily see on the stir, the T1, and the diffusion. But again, we're looking at a lot of data. You have to really carefully look everywhere. There's a faint lesion here in the brain on T1. There's some asymmetry on the T2 signal, and there was a focal lesion with some surrounding edema. Follow-up imaging in 1 month showed that it increased in size, was actually extramedullary manifestation of disease. So again, there's the gorilla hiding out, and we have to make sure not to miss it. So what happened in the end? Dewey-Salmon incorporated the findings that the studies of Bauer and another study of them actually showed, and changed the staging system in 2003. So now you have whole body MRI and FDG PET as a staging modality, as a standard of care there. Now, if skeletal survey is not working, what about whole body CT? And that study was also done by Bauer and Melnick, and they showed that if you compare CT to STIR and T1 imaging, although it's of course longer than the CT acquisition, it basically understages the disease all the time compared to the MRI stages. So it's not as precise and appropriate. What about PET and PET-CT? Dury themselves came up with a study, looked at PET and compared it to the different disease stages that they had in their study. And what they found is if you have a negative PET signal, it predicts stable inactive disease. If you have active disease, you will find focal and diffuse infiltration on the PET, whereas the skeletal survey again was quite often negative. They found extramedullary uptake, which is a sign of poor prognosis in active and recurrence patients. And if you have a persistent signal on FD-PET after induction therapy, that means it's an indicator of early relapse. Then how about PET-CT versus whole body MRI? How does it compare? And here's a study on stem cell treatment. Basically what they found is that PET is more suitable for determination of the remission status. That's because whole body MRI actually showed a lot of false positive findings, since the lesions that you see initially, they persist, but they may be non-viable. And that resulted in a poor accuracy of whole body MRI compared to PET in their study. Interestingly, PET-CT found a breast cancer in this study group, whereas it was only retrospectively seen on whole body MRI. So just another remark, there's the gorilla hiding in plain sight again. Another study that actually looked at active multiple myeloma and then compared PET to whole body MRI. What they found it's actually quite similar, or maybe slightly better for whole body MRI in detecting active disease. And they concluded if you combine both together, you reach 100% specificity. And that might be an interesting approach for clinical trials where you want to assess a response to new drugs, that with the combined setup, you can really correctly stage the disease. Now, why is it that the standard methods, skeletal survey and the CT, are not as good as PET and whole body MRI? It's because on CT and skeletal survey, we only look at the indirect footprint that the disease leaves. We only see the lytic lesions once they show up. We don't see the diffuse infiltration in the bone marrow itself, and that's what we directly visualize with whole body MRI and PET. There are also some advanced applications you can do. If you look at diffusion-weighted imaging, not only lesion detection, but you can look at ADC values. In this study, they compared the ADC values with the M component, the serum concentration, and what they found is the M component is like a biomarker of disease activity and aggressiveness, that it correlates. Here are some images of initial imaging and then the post-treatment imaging. You can see you have two lesions here. The spinal lesion disappeared on follow-up, and the iliac bone lesion here did have some signal intensity changes and also some changes in the ADC, reflecting an increased ADC after treatment, which means less cellularity as a response to treatment. And they were also able to separate out different groups of multiple myeloma depending on the serum component. So if you have a high ADC value, meaning less cellularity, they also had fewer serum component concentrations in their blood, whereas if you had a high serum component concentration in the blood, ADC was lower, meaning higher cellularity, possibly more diffuse infiltration or densely packed cells. You can also do perfusion imaging on multiple myeloma. On this study, what they did is basically doing time intensity curves based on the areas where you place the ROIs. What you get is a wash-in, wash-out curve, basically, that you can characterize by different parameters, such as the slope. And when you look at the wash-in slope, they found you were able to differentiate the different disease groups and a control that they have here. Be reminded that's a logarithmic scale. Although they said it's a significant difference here, there's also some overlap between the control groups, the inactive diseases, and the active disease. But looking at pre- and post-therapy you'd see that the wash-in slope was much steeper pre-therapy, and then post-therapy approached normal values. And it can be seen here. The red curve is the steep active disease wash-in slope and a faster wash-out compared to all the other groups of controls in inactive disease. Now we've seen what the different sequences and contrasts can do in multiple myeloma. I would like to move on and see how it performs in other diseases. In multiple myeloma, in lymphoma, they did this study where they looked at how the different sequences would perform in terms of sensitivity, and also did some ADC measurements. So it's diffuse large B-cell lymphoma imaging prior and 1 week after chemotherapy. And they found that the FATZT2 was actually best for lesion detection and for assessing chemotherapy efficacy. But ADC values offered some prognostic value as well, and we'll show you that. Here's the results. You can see the T2 FATZ outperformed the other sequences based on contrast ratios quite well. And if you look at the ADC measurements, you can see that initial imaging here, you have low ADC values, again meaning high cellularity, and after treatment you have a higher ADC, meaning you have the loss of cellularity, possibly due to response to therapy, and then went well with the tumor volume that initially was quite high, and then went down on post-imaging or post-therapy imaging. And here's an example. I just want to draw your attention to the ADC maps here. This is pre, this is post-therapy. You can see darkness signal here in this big lesion in the cervical area. It has, after treatment, there's increased signals, so we have higher ADC, and the area is also quite smaller. So we can use that to look at response to treatment. Now what about CT that we commonly use versus whole body MRI for lymphoma? In this study, they looked how it performed in terms of staging the disease, and PET was the standard reference there, or bone marrow biopsy. So whole body MRI without diffusion was quite equal in most cases to CT, but in 26% resulted in a higher stage, which was correct in 3 cases, versus in 4 others was not correct. But if you add diffusion-weighted imaging, you get the same ratio there, but the overstaging is correct in most of the cases then. Here's a nice example from that publication. This is the whole body MR, was able to depict the lesion here in the femoral neck, which was not seen on the CT, was later confirmed by PET imaging and by follow-up MR imaging. Now, what about whole body MRI versus PET-CT in lymphoma? This is another study that showed adding diffusion-weighted imaging increases your number of true positive lesions up to 97%, slightly increases the false positive rate, but certainly decreases the false negative rate that we'll have. And in roughly 90% of the cases, it's concordant with PET-CT. This study did a different approach. It had whole body MRI with PET-CT, and they looked at bone marrow involvement in lymphoma. Now, their conclusion basically was that both modalities are similar in their diagnostic performance, but interestingly, both modalities were quite poor in their performance in looking at indolent lymphomas, but were both really good at looking at aggressive lymphomas. So again, the more disease you have, it's actually better to detect for both modalities, but they performed similarly. So if that's the strong side of MR here, that to detect bone lesions, it makes sense to look for bone metastases, and this meta-analysis did that, looked at 7 studies that compared whole body MRI with skeletal scintigraphy, and basically found that both modalities perform in the same way and can replace them. And this particular study, using a more modern approach with a fast Dixon technique, they basically found that whole body MRI versus skeletal scintigraphy shared the same, was actually better, in terms of sensitivity, but slightly less in terms of specificity. The added value here was that whole body MRI detected all the liver metastases. Just a quick side note, when you do Dixon imaging, you have one sequence which can yield 4 sets of images. You can increase the number of data or the number of images you have to read tremendously. This is an example from another publication looking for metastases in RCC. You can see the skeletal scintigraphy did not show this femoral lesion here, which is actually quite small. MRI picked it up, and follow-up imaging after treatment here shows the lesion increased in size. Now, moving on to malignant melanoma, can you use it in that regard? You can find lesions everywhere in malignant melanoma, we know that. So they compared whole body MRI with FDG PET CT. Reference was histology or follow-up imaging. And what they found basically that whole body MRI outperformed PET CT slightly. So that's interesting. Diffusion-weighted imaging added, again, additional lesions that you wouldn't see with standard MRI protocols. And if you look at the detailed findings here, you would see that in the lung, MRI outperformed PET CT, in the skeletal system, outperformed slightly, and of course in the liver, it did much better than PET CT. And that's the common problem with PET CT. You have the heterogeneous background signal in the liver. Yes, they detected one lesion there, but diffusion-weighted imaging was able to detect another there. What can you do with ADC measurements in malignant melanoma? And that's a case from a colleague of mine. He was so nice to give it to me. You can see it's a case with a metastatic axillary lymph node in malignant melanoma. It's growing over time here. And during treatment, ADC values initially decrease, which can also be seen as a sign of early response due to cell swelling. But then, over time, ADC values increase again. Again, this is a loss of cellularity and a sign of response. Moving on to lung cancer, can you use whole body MRI to stage lung cancer? And this is a nice study done, whole body MRI versus PET CT. And what they basically found that it's quite similar to PET CT, in some cases a bit inferior if you want to stage the primary tumor, if you do TNN staging, and if you want to find the accurate lymph node groups. But overall staging, it's a bit inferior to PET CT. Nice image showing a very small lung cancer here compared of the diffusion-weighted imaging fused with the morphologic sequence and the PET findings there. Can you find recurrence in lung cancer? Whole body MRI versus PET CT. Again, follow-up in histopathology as a reference. And here we see that they are actually quite equal in detecting recurrence and compared to PET CT. And both were really strongly correlated in that study. This is a more complex study. I don't want to go into too many details because we used a very elaborate setup of protocols, but what they basically found that whole body MRI is at least similar to PET CT and in some instances superior in detecting recurrence in lung cancer. Now let's move on to a summary and try to wrap it up in a way that we can put together what we just heard. One interesting article that I can give you as a recommendation, it's this one. They did a meta-analysis, a systematic review of 44 articles on whole body MRI versus PET CT, and their conclusion basically is that yes, it's a valid alternative method, although we are still missing some data. We need larger studies, and we don't have a clue if it's cost effective or not. And what I'm trying to give you here is the combination of the data that's out there and my own perspective. And if we look at the technical sides, how whole body MRI performs with the rest of the competition, I think it's the contrast. It's also the lesion size where it's superior. It can detect really small lesions due to its contrast to background signal. It has problems in acquisition time, we heard that, and there's contraindications. But interestingly, there's only one study that really looked into that. PET CT is twice as expensive, at least in that setting, compared to whole body MRI. Now, what about the different diseases and the competition? In most cases, you can have similar performance of PET CT and whole body MRI. There are certain instances in the skeletal system, in the brain, where whole body MRI outperforms the PET and the PET CT part. Now, if you look at the different regions, where does whole body MRI come into play compared to PET CT? Again, they're quite similar, except in the brain, you'll have advantages, as we've seen in the liver, maybe in the pelvic area, if you look at PET versus MRI for the MRI part. So as a summary, we've seen there's lots of data out there. Sometimes the quality of the data is not so good. Mostly the perspective is really positive. The advantages are really in detecting small lesions in various organs that are problematic for the main competitor, the PET CT. However, in staging instances, PET CT is still superior, That's because in whole body MRI you get more lesions that are false positive compared to PET-CT. You should and could use diffusion-weighted imaging because it is better for lesion detection if you've seen that and offers prognostic information that you can utilize. And as we heard also, if you have patients who need regular follow-up quite often, it might be a suitable replacement for modalities that usually come with radiation exposure. We also have to look into this, how much healthcare costs that would create, incidental findings, how to cope with that, and we don't know what the actual exam actually costs in a setting treating a patient. But it is a valid alternative method. Now as an outlook, I just tried to put together some ideas there. What about doing a focused exam like a typical prostate or breast cancer workup on patients and combining that with a whole body MRI setup to look for distant metastases? There's of course MRI PET, and we have to see how that comes into play for the various diseases. But if you don't have a PET machine, you're not looking into buying one, there's the option to do MRI PET fusion. And what we also need is we need advanced solutions to read all that data. To read that data, to record the findings, and to process them. Just as the last thing here, give you an idea what MRI PET fusion may look like. That's a pictorial assay, and they nicely showed that if you fuse the images of the PET and the MR here in the lung cancer patient, you can actually see that the MR part was able to depict the chest wall infiltration here that wasn't seen by the PET. You can use the MR, the morphologic sequence, quite nicely, as in this case, to find the lymph node metastases that was adjacent to the ovary here and make sure that's actually the lymph node metastases and not the ovary showing up on the PET part. And they also showed in various other metastasized diseases, again, that detecting lesions in the brain is really the strong side of whole body MRI. And with that, thank you for the attention, and watch out for the gorilla.
Yeah, thank you very much, Tobias. We are very good in terms of time, so if there are any comments or... Yes, please.
In your own institution, have you managed to replace almost bone scans for diseases such as prostate cancer as part of your workup? Would you still use this as an additional test?
Well, would you mind repeating the question first, that everyone hears the question?
So the question is, if we were able to replace skeletal scintigraphy, for instance, in prostate cancer, with whole body MRI. We actually did not. We're still using the standard methods because they are fast, they're reliable, and you get reimbursed for that. So that is something we have to look into. I mean, there's a lot of data that you could use it, and it's better. The question is also if it ultimately affects patient management. This is something where the data is not so sufficient so far.
Yes, please.
Not sure if I understand the question. So you're asking if we can differentiate.
Yes, I want to know what is the sensitivity of what MRI in patients on treatment.
In general, or well, I mean, the meta-analysis that I showed you, if you combine all those numbers together, and it's actually a bit problematic because you have so different data sources and they did the studies differently with different standard references, but you approach the same as basically the PET-CT has. So it's a quite high sensitivity and specificity in the range of the 90%. But looking at the individual cases is a bit different, and it also depends. I mean, giving a number is always good, and you can put that out there, but it depends on the performance of your department. It depends on the protocols you use. We've seen that some people only use stir imaging, and that's it. And some people use anything from T1, stir imaging, diffusion-weighted imaging, plus contrast-enhanced imaging. So we're not sure yet what is the optimal protocol, And then you also have the readers to look into that. And the more studies you look at, actually, the more gorillas, so to say, you'll find. You'll see that they often report that initially some lesions were not seen and were only detected on follow-up. So that tells you that we have to really take care of the problem of missing the lesions. Maybe the technical side provides us the right amount of information, but it's us, the radiologists, that have to take care of these findings, really catalog these findings, make sure that we capture them all.
Okay. Now, before we move on, who's actually using whole body MR in oncologic applications? Could I get a raise of hands? So this is a substantial number. Guessing here is probably 40 to 45%. And who is happy with the reimbursement situation? Oh. I think this is a very general question for radiologists. When you ask them, are you happy with the reimbursement question? So let me rephrase that. Who is, compared to the other situations, who actually believes that, yes, we are fairly reasonably compensated for our services? Okay. Okay, so the minority. Okay, thank you very much, Tobias. We are moving on now. And Prakash, he's from Texas Children's Hospital. He will focus on the pediatric applications. And I think here, obviously, radiation is of even greater importance. And this is why we thought we would allocate a whole talk on these applications. So Prakash, please.
So I want to start with a short story first before I get into my talk. I was doing a grand round on this topic with some of the clinicians back at Texas Children's. And of course, I showed them all the spectacular images and went through a lot of data and portrayed whole body MR as the best investigation that's out there. And guess what? After the talk was done, which set of clinicians came to me first saying, we need to scan all our patients using whole body MR? It was the ID physicians. It was the infectious disease physicians. And just a word of caution with this technique. We have to use it judiciously, simply because the clinicians, once they realize that there is a technique where we can scan the whole body with something, they'll latch on to it. So something like multifocal infection, especially in children, you lack spatial resolution when we do whole body MR. Clearly, we know that there are areas of asymmetric hyperintensity in the metaphysis and such, which you do need good spatial resolution to look at. So clearly, there are good indications for it, but we certainly need to do a lot more work in coming down with which ones we definitely can use whole body MR imaging with. I'm going to share some of my experience at Texas Children's with you and show you some case examples as to where we've been using it and where we've found maximum benefit, and the protocol sort of revolve around those areas. So this is the traditional method, obviously, of doing whole body imaging. We still do bone scan, we still do technician bone scan for a lot of our indications, and changing that paradigm clearly for a lot of things is going to be challenging and will require a lot of work. So as I go on with this talk, I'm going to discuss some of the principles at the risk of repetition. Two of my distinguished colleagues have gone over some of this stuff, some magnet specifications, go over some of the pediatric applications. And throughout the course of the talk, I will be reviewing a lot of the literature that's out there, because that's really key in deciding whether we can incorporate these protocols in our practice, and some future directions. And I will show you a few case examples of MR PET, since we were fortunate to acquire one a few months ago. Although it's a very brief experience yet, since it's only 6 months old. So clearly, in terms of coverage, whole body imaging, you're covering from the vertex to the toes. And again, this is all over the place, because the way I have set up the protocols, the brain scanning is done as a whole separate acquisition, and then the rest of the body is done as a whole body MR acquisition. So although we do call it vertex to toes, a lot of people scan the brain as a separate exam for good reason. A lot of these acquisitions, as we've seen, are coronal acquisitions, simply because it's faster and easier to look at. most of the multi-system diseases can be evaluated in one exam from a standpoint of staging. Clearly, we saw that with the lymphoma cases. And then all of this can be performed in children in a single session of sedation, which is key. And clearly, we all know that it's the radiation exposure that's driving a lot of our MR applications. And just like we had mentioned earlier, the acquisition is performed at multiple stations using a lot of these sequences. So when we started doing whole body MR, we would do it with the inbuilt quadrature body coil or the inbuilt coil in the magnet, which was integrated in the bore. But it did suffer from some of the SNR issues where the signal to noise ratio was clearly lower, although we've come a long way even with the Q body scanning. But with the advent of sliding MR table platforms, where we saw these examples in the schematics on the earlier talks with regards to the placement of the coils and how the patient can be moved on the table with static coils being present both anterior and posterior with acquisition of the images at the same time. And then recently with the advent of the multi-channel surface coil system, we have excellent resolution on the images because of the number of coil elements that are incorporated in this system. So these are some of the images from a Q body perspective. We've come a long way, and even the resolution with just doing imaging with the integrated coil and the magnet, you can see from these images the stir and the T1s, they're fairly good, and you can clearly get very good tissue contrast on these images. So one question I'm always asked is 3 Tesla versus 1.5. What do you use for your whole body MR imaging? And currently, I still do a lot of whole body MR on 1.5. But the MR PET has a 3 Tesla system on it, and so it's been a learning experience in trying to get the sequences to look better and better on the 3T system because of the inherent disadvantages of heterogeneous signal intensities and susceptibility artifacts on the 3T system. But clearly, once we optimize it, the advantage of the higher signal-to-noise ratio can be exploited. So these were some of our original images with Q body, where there was a lot of graininess on the images. The signal was very heterogeneous, and although you can still see that lymphatic malformation on this T2 in the region of the left knee within the soft tissues, now we've optimized the sequences for them to look much better, and I'll show you some of the examples later. One of my colleagues did mention that which sequences do we use for whole body imaging? And I will tell you this, that there is no clear consensus as to which sequences go on to make up your protocol. And in talking to my colleagues from other institutions, everybody has their own way of doing this, which hopefully in the near future, it'll be more standardized. But STIR is sort of the linchpin. It really is your main sequence because of the homogeneous signal intensity, most pathologies being hyperintense, and excellent marrow evaluation on the STIR sequence. Although it has some inherent disadvantages in the fact that osteoblastic metastases can be a challenge. So these are typically how the whole body STIR sequences on our scanners look like, where the coverage is really from the base of the neck all the way down. And you can see you get excellent tissue contrast. The intra-abdominal structures are very well seen. And when we use respiratory compensation techniques, which we've started to do in pediatrics, even the evaluation of the lungs is fairly good. What other sequences do we use other than the STIR? T1 clearly excellent for marrow, so we've been using the T1 turbospin echo. There is a study out there with use of steady state free precession sequence, the SSFP sequence, which is the main sequence used for cardiac imaging, where they mentioned that it had excellent anatomic depiction, but the localization of metastases was very limited on this particular sequence. And of course, we have the fast spin echo, or the single shot technique as we call it, which is very popular. It's fast, and it's relatively insensitive to motion, especially from bowel motion, and hence it's used a lot for whole body imaging, this fast spin echo or single shot technique. So this is the T2 turbo spin echo that we have incorporated as part of the whole body protocol. Again, very crisp images, and you get very good definition of the morphology. Post-contrast imaging, again, this is one of those sequences which not everybody is doing post-contrast imaging as part of the whole body protocols, and we certainly don't do post-contrast imaging for a lot of our whole body protocols simply because of the time factor associated with doing this sequence. And we all are familiar with the gradient echo T1, which is our T1 post-contrast sequence that we use for looking at contrast kinetics and such. And it's good for staging of tumors, and especially for conspicity of liver lesions and such, where you want a dynamic phase looking at wash in, wash out of lesions. We did touch a lot upon diffusion-weighted imaging, and with the advent of DWIBS, which is the whole body diffusion with background signal suppression, clearly I feel this is one sequence that's going to be part and parcel of whole body imaging for a while, especially since we can do it free breathing. So for pediatric applications, that's a big, big bonus. And it's got very homogeneous fat suppression, and you can do it with high B values. We saw the B value of 800 being used for DWIBS. So this is the protocol at our institution currently for a lot of the whole body imaging that we do. STIR typically in the coronal plane. I showed you some of the T1 TSC, and the single shot we use predominantly for the chest, abdomen, and pelvis. And we don't do post-contrast imaging, and diffusion as yet is something that I don't use routinely for whole body, although it's incorporated as part of our whole body MR PET protocols. So I'm going to jump into some of the pediatric applications that we've used it for. Clearly we saw some excellent data on lymphoma. It is the third most common childhood malignancy, and although PET-CT is still the mainstay, definitely whole body MR is a viable alternative for diagnosis of lymphoma, and then MR PET, as I'll show you in some examples, excellent alternative to PET-CT, and we hope that it'll replace PET-CT at some point. So these are a couple of papers where STIR was used for staging of lymphoma in children, dates back to 2004, and it was superior, in fact, to the conventional imaging techniques, and that was especially for detection of marrow involvement. And another comparison of whole body MR and CT for staging of lymphoma, published in the AJR in 2005, demonstrated that lymph nodes larger than 12 millimeter in short axis MRI compared very well with CT for the detection. And this was a prospective study, fairly recent, from 2010, published in Radiology, focusing on pediatric lymphoma, where we compared whole body STIR MR imaging with PET-CT as reference for the initial staging of lymphoma. And the sensitivity and specificity for nodal disease was very high, 98 and 99%, and for extranodal disease was also greater than 90%. So it augurs well for the technique as such, especially given the prospective design of the study. So this is a case example that we have on a patient with STIR and T2 images, and you can see in the mediastinum the mass lesion that can be diagnosed in a patient who you cannot get a CT scan or a PET-CT is not performed. And with MR PET, clearly I'll show you some examples where we can comment on the activity within the mass lesion as well. What about benign versus malignant lymphadenopathy? That's always been a challenge in differentiating benign from malignant. And this paper found that there's a high sensitivity and specificity with lymph nodes when size is used to facilitate the differentiation. And more than 1 centimeter in short axis was what was used as the cutoff. And hopefully with diffusion-weighted imaging, we will overcome that barrier. What about the other oncologic applications with solid tumors? Detection of metastases is clearly key with this. With response to treatment is the main answer that we're trying to provide with the non-lymphomatous solid tumors. And I want to draw your attention to this multi-center study published in 2012, fairly recent again, where whole body MR was used for staging of the malignant tumors in pediatric patients. And it did demonstrate improved accuracy in detecting distant metastases in non-lymphomatous tumors. And they did detect more skeletal metastases, but fewer lung mets. Although the conclusion of the study did mention that as the initial study of choice for staging pediatric malignant tumors, probably whole body MR is not justified yet, especially if the tumors have spread to the lungs and the solid organs. And these are the papers, some of which we saw earlier too, but a lot of these focus on the pediatric patients. And they did find whole body MR comparable to skeletal scintigraphy and PET-CT for skeletal metastases. So something to bear in mind moving forward, where again, as an alternative, whole body MR would clearly suffice. This is where I find whole body imaging really making a difference, and somewhere where the oncologists are really driving the use of whole body MR is for screening in cancer predisposition syndromes. And this is our major workload with regards to doing whole body MR. And the big one, of course, is Li-Fraumeni, the P53 mutation. We've recently started doing it for the hereditary paraganglioma syndromes. Neuroblastoma screening and retinoblastoma are two that we, of course, don't routinely use, but there are some fleeting case reports, especially with regards to neuroblastoma screening, where you can use whole body MR. Anything that avoids radiation, of course, is something we should look into in trying to optimize our imaging. Again, not yet on the forefront, because when I speak with my colleagues, they're still, we need to get a CT because we're used to doing CT for neuroblastoma, but something that's out there as an alternative. This was an article from 2011 in Radiographics where whole body MR was recommended for screening of Li-Fraumeni. Clearly, these patients are predisposed to develop cancers, including leukemia, adrenocortical carcinoma, soft tissue sarcomas, and brain tumors. And our protocol for Li-Fraumeni, as I was mentioning to you earlier, the brain part of the exam is done as a separate exam, and then the rest of the body we scan with STIR T1s and single-shot T2 weighted images through the chest, abdomen, and pelvis. And this does include the extremities, both the upper and lower, looking for any marrow abnormalities, searching for any occult sarcomas or early sarcomas in these patients with P53 mutation. And then if we do detect an abnormality, that does go on to further scanning tailored to that part of the body, wherever we find the abnormality. Yet in the 14-odd patients or Li-Fraumeni patients that we have scanned, we've had one positive case where there was a lesion in the proximal humerus that was biopsied and came back as a simple bone cyst. So yet we don't have a positive case yet, but that's something that's recommended for screening in these set of complex patients. That's the single shot T2 through the chest, abdomen, pelvis. This whole protocol takes us about 35 minutes to perform. And the brain part of the exam clearly is a separate exam, as I said, which takes its own 35 minutes. Although we do both the exams when sedation is required under one anesthesia. So this is the other set of the syndrome that we've just started doing whole body MR screening for, is the hereditary paraganglioma families. And these are patients with germline mutations in one of the ST8 genes, and they are at an increased risk of developing paragangliomas and pheochromocytomas. And whole body MR seems to have a high sensitivity for these tumors, even better than biochemical testing. And hence, this is something that we'll be seeing more and more being performed as a screening measure, just like we saw with the Li-Fraumeni patients. And this was the case report that came out of Spain, where they used it in a patient with opsoclonus myoclonus. And interestingly, one of my distinguished oncologists had read this case report, and he came up to me and said, you know what, why don't we start doing whole body MR for these patients? And like I said, obviously this is something that I would do with someone with bad renal function, or if the parents had an issue with doing a radiation-induced study like CT. But it clearly is promising even in this subset of patients, and we'll have to wait and see if it ever takes over CT for neuroblastoma screening. Non-oncologic applications, there's a big list of applications in children out there. And some of them have been studied, but they're sort of fleeting studies, and clearly more work needs to be done to see which of these we are able to target with whole body MR. But clearly LCH, we saw the examples of chronic recurrent multifocal osteomyelitis, in dermatomyositis, non-accidental trauma, and whole body fat distribution. These are the ones that I find very exciting in looking with whole body MR. This was the paper on the typical patterns of bone involvement in whole body MR of patients with CRMO. And they did find on this study that there was clearly a characteristic involvement which was nicely picked up by whole body MR. And just based on that, both from a diagnostic standpoint as to which all areas are involved, whole body MR was the way to go with chronic recurrent multifocal osteomyelitis. Although clearly, of course, this patient population is not as dense. I've seen only 2 cases of CRMO in the last 3 years at my institution. What about child abuse? What about non-accidental trauma? as long as I can remember, we've done skeletal surveys for this set of patients. And absolutely everyone in my section is used to seeing skeletal surveys for non-accidental trauma. But it does carry a significant radiation risk. We sometimes do 2, 3 skeletal surveys out on these kids because some of these fractures are subacute and they get picked up better on a follow-up skeletal survey. So can we use whole body MR for this? At least this particular paper published in AJR in 2010 did not find good sort of numbers in trying to use it for non-accidental trauma. And especially they found that for metaphyseal lesions and rib fractures, which are the high specificity indicators of child abuse, it cannot replace skeletal survey, but it may complement it by identifying soft tissue abnormalities. But yes, it would entail sedation at times, and it is lengthy, and clearly not somewhere that we can replace skeletal survey yet. This was an exciting indication, the use of whole body MR in familial partial lipodystrophy. And they did find that from the redistribution of the fat in the body, wherein the cervical and the visceral adipose tissue increased in this set of patients on treatment, and the hepatic fat fraction decreased, they were able to demonstrate the improvement with biochemical indexes of insulin resistance. And it certainly did help demonstrate the subclinical changes of fat deposition in this set of familial partial lipodystrophy patients. So this is something we've just started to do, and we've done it on 1 patient yet, and clearly looks like it's beneficial in commenting on the response to treatment in this subset of patients with familial partial lipodystrophy. Another exciting area where we've been using whole body MR is looking at diffuse vascular malformations. I'm a cardiac imager, and I realize the challenges of a lot of the vasculitis we see, a lot of the vascular malformations we see, and this technique is very, very robust, whole body MRI and MRA, in looking for these diffuse vascular malformations. And I've just mentioned a few of these, but there's a whole host of much rarer ones that are out there that you can use it for. But Klippel-Trenaunay and Parkes-Weber, the P10 mutations, Takayasu arthritis, arterial tortuosity syndrome, and for diffuse lymphatic malformations, it's clearly a viable test. It's a great test in starting and following up these patients. This is an example on a patient with Klippel-Trenaunay syndrome, where you can see that the right lower extremity entirely is replaced by these hyperintensities, which are really dysplastic venous structures. And it clearly guides the interventional radiologist in treating these patients, because they can, in one go, see the extent of the malformation, and then when you couple it with an MR angiography, time resolved with temporal undersampling using a technique like keyhole or tricks, and get the dynamic times to less than a second. We're able to look at AV fistulae running to these lesions, tiny arterial feeders going to these lesions. Clearly helps the interventional radiologist to create a roadmap before they go in trying to sclerose these very complex and challenging lesions. Just another example of KTS, Klippel-Trenaunay-Weber, where you can see the asymmetric hypertrophy of that lower extremity. A lot of the hyperintensities from venous low flow venous malformation that we tend to see in these patients. This is an interesting case of a child we had a few months ago, where we had a neonate to present with what's called as CLOVE syndrome, which stands for congenital lipomatous overgrowth with vascular malformation. And using our whole body sequences, we were able to demonstrate the abnormality wherein all of this dysplastic fat, even on the STIR sequence, did not sat out, because it was dysplastic lipomatous tissue in this child. And you can see there were pockets of lymphatic fluid collection apart from having this lipomatous overgrowth, and also a hemangioma in the lower chest. So give a broad overview of all the abnormalities in this child with a good whole body technique. This is a patient with a lymphatic malformation, which was centered around the scrotum. You can see on the STIR, it's bright, dark on T1, and has this kind of rim enhancement that you'd expect on post-contrast images, but also has a microcystic component of the malformation down in the leg. Again, something with whole body technique where you can target diffuse malformations. Whole body MRA, I'm not going to spend a lot of time on this. My colleague has already gone over a lot of the technical specifications and examples. But when we do whole body MR angiography, clearly it's tailored to the size of the patient, as to what our coverage is going to be. Can I do the whole MRA using the Q body, or can I do it with a large coil, such as a torso coil with a 55 centimeter field of view? Use of phased array coil clearly is something that I'm looking for, because I cannot do parallel imaging unless I use the phased array coil. So I cannot bring down those dynamic times efficiently, maintaining a good spatial resolution, until I'm allowed to do parallel imaging, which is especially of benefit in children. But the moving table technique, or the sliding table platform, has helped immensely in following the vessels. And as I mentioned earlier, we use the temporal undersampling technique. And we have moved towards using blood pool contrast agent, or gadophosphacet, Ablavar, for our MR angiography. And that has certainly helped, because other than doing first pass imaging, which we were able to do with the traditional contrast agents, the steady state imaging with Ablavar is what's key. And we certainly exploit that on our MR angiograms. This is the example of the same kid with the Clove syndrome. And you can see here the dysplastic venous structures out in the soft tissues, and the narrowing in the thoracic aorta up here, which on the whole body technique you're able to visualize a lot of the abnormalities globally. Multifocal infection. This was the short story that I was mentioning to you earlier. My ID physicians ask for doing whole body in children all the time for infection, and this is something we sort of discourage just because of the lack of spatial resolution. Clearly there's a time and cost associated with it, and it does have low specificity at times because of the asymmetric metaphyseal hyperintense areas, which are so common in children. I'm going to shift gears and go on to a little bit on MR PET with whole body MR. This is a very, very robust technique that has come to the fore. It's fairly recent. We've been very fortunate to acquire a whole MR PET system a few months ago, and yet we've been using it predominantly for lymphoma. But yes, we're trying to look into more and more indications to do MR PET to see if we can find an alternative to PET CT because of the radiation aspects associated with it. A lot of our sequences on whole body MR are respiratory triggered, and we do that simply because we get better evaluation of the lungs. We eliminate the respiratory motion misregistration artifacts doing it. It does add to the time a little bit just because it has the triggering to go with it. There's a lot of reliance on stir. We have not yet started using the Dixon sequence, but that's something that we're looking into. But it does generate 4 sets of sequences, like my colleague mentioned, and so it's a lot more that we have to look at. The current limitation is lung assessment in terms of looking at these smaller nodules less than 1 centimeter, and that's still a limitation with whole body MR imaging. So we have the hybrid or the sequential whole body MR PET system, wherein the patient is sort of moved from the MR to the PET, and the PET system is protected by a lot of magnetic shielding, where the photomultiplier tubes are protected by this special shielding in these patients. But as you can see, because the patient is not moving at all, the images clearly are not degraded because of the lack of the patient moving around and so on. We don't have to transport the patient from one place to the other for acquisition of the PET. This is an example of a patient, 16-year-old girl, who had an initial diagnosis on this sequence. You can see a mass in the mediastinum, T2 bright, was a lymphoma, and then post-treatment on the follow-up had a reduction in the size of the tumor. And we diagnosed and followed this patient entirely with MR PET. And of course, right now we're doing PET CT and MR PET on the patients until we get to a point where our attenuation correction is validated. And hopefully soon our attenuation correction is going to be validated, so we can do only whole body MR PET instead of subjecting both to the patients. But this is the attenuation correction map on the same patient generated, which is showing the disease in the mediastinum. Same patient with T2 images, where you get a global look at the rest of the abdomen, looking for liver lesions, any adenopathy in the abdomen, again showing a treatment response there, where the mass is decreasing in size 2 months out from treatment. And these are the fused images that are generated on the MR PET, and does very nicely demonstrates the activity within the mass in the neck as well as in the mediastinum. And you can see that on the post-treatment, there is clearly a decrease in the activity in the region, which goes along with the decrease in size of the mass. Because somebody did ask a question as to what do you do with diffusion when what if the size of the mass is the same and the diffusion is showing no restriction on the follow-up? What does that mean? I think a lot of that we don't understand yet, because when we use chemotherapy agents, when we use steroids, there is clearly a change in the way the tumor cellularity responds to that. So clearly when the size decrease goes hand in hand with it, it certainly means a treatment response. Axial images in the same patient showing the response in the neck and also in the mediastinum. This is an example of another patient with Rosai-Dorfman disease, which is a histiocytic response. And on this AC map, you can see the areas of involvement in the region of the elbow, vertebral bodies, in the lower extremities. And then once we see the fused images, you'll notice the area of activity in the region of the calcaneum in the foot, the involvement of the epitrochlear lymph nodes in the elbow, and the involvement of the vertebral bodies from the activity. So in summary, we saw some examples where whole body MR is increasingly being used in pediatric patients clearly, where we're trying to avoid radiation by using this technique. Certainly, it's a potpourri of sequences. There's a lot of sequences out there. There is no clear consensus as to what to use, but STIR seems to be the linchpin, the key sequence that most people are using for whole body imaging. It's got a huge role to play in cancer predisposition syndromes and Li-Fraumeni patients, the SDH mutation patients. These are two which definitely are well established in the literature where you can use whole body MR for screening these patients for neoplasms. The use of DWIBs will clearly provide functional information, and we need a lot more work in seeing how the DWIBs will go. And the hope is that whole body MR PET will replace PET CT, at least for the follow-up of lymphoma moving forward. And then we saw some of the vascular cases where we use whole body MR and MRA, and it's extremely useful. And as Dr. Merkel alluded to half an hour earlier, billing for these studies still remains an issue. Everybody has their own way of billing for these studies because we don't have an established ICD code wherein you can bill for this particular study. I can tell you what we do. We bill this as a limited exam. They do not get billed for every part of their body. They get billed as a limited exam, and so the charge, I think, is somewhere between $2,000 to $3,000. And then depending on the payer, the hospital, of course, receives less than that. But it's not a charge that it's a separate brain or separate chest, separate abdomen. We do it as a limited charge for it. I'm not saying that is the way to go. Clearly does require a clear consensus as to how we have to approach this, but it remains an issue with most hospitals. Thank you very much.